All right, welcome back, everyone. We're going to now begin the panel portion of our time together here today. Leading the panel, you all were introduced to him earlier, is Dr. Jack Lewin. He is the chairman of the board for the National Coalition on Healthcare. We also have with us Francisco Silva. He is the general counsel and vice president of the California Medical Association. John Crane, the CEO of CAPG and the voice of Accountable Physicians Group. Third on the lineup is Ken Kaiser, the director of the Institute for Population Health Improvement and a distinguished professor in the UC Davis School of Medicine. And last but obviously not least is Janet Liang, president of the Northern California region of Kaiser Foundation Health Plan. Please join me in welcoming our panel of providers.
It's really exciting to be here with this panel. We're going to kind of motor mouth through this whole thing because we have a little over 40 minutes to do this today. But the idea, I suggested to all these panelists before we got here that there were two questions initially in 5 minutes that they would talk about. One was, if you had all the power in the world, what would you do to improve the affordability of care in California, considering that affordability is access as well as quality and outcomes. It's all linked together, but if we don't have any money to pay for it, if we're vampires and all the other parts of the health society and social networks, we're going to be in trouble. So that was the first. And the second is, what are the barriers to accomplishing that? And then there'll be something else to follow that maybe, and then we'll have a little open it up if we have time. I wanted to just mention that, since these are such tumultuous times, people are walking around like zombies, dazed in Washington, D.C. these days because they're just so, perplexed as to what we're trying to do. We're spending $3.3 trillion on healthcare, and yet we have policymakers in Congress who are talking about dismantling the Medicaid program, taking all the entitlement out of it, getting rid of CHIP, thinking about making Medicare a non-entitlement program, completely transforming that. Reproductive rights, on the table to be sacrificed. There's so much going on. It's perplexing. But we seem to have a paucity of new and appropriate ideas to offer those policymakers in the future out there. And I think that NCHC, if you put all of our members together, all the organizations, we represent 150 million Americans, which is kind of overwhelming. We also, if clarity is power, and I think it is, the idea is what could that clarity be? And obviously there are going to be diverse views about it, but we'd like to hear today from each of you as to what you think. Now, Francisco and I work together at the California Medical Association, and what you don't know about him, though, is he started out in Sonora, right? In Mexico.
I was born in Mexico, yes.
Yeah. And, self-made family, the whole family has been...
undocumented, as a matter of fact.
Yes, and he's an undocumented guy, but anyway, what an accomplished guy, and you've been a champion for Medicaid as well. So let me just throw the two questions to you first, Francisco.
Sure.
Well, thank you. I think that's a reward for knowing you for a long time that I get to go first, right?
Mm-hmm.
I think in terms of the question of strategies, and this is in line, I think, with what the Secretary was talking about. One of the strategies as we look at payment reform is that we cannot look at new payment policies without considering the impact on competition. And Professor Gaynor just came out with a report that really looks at what that can impact and how it can impact providers in the insurance market and patients and affordability. With that in mind, I think we have to look at, as a strategy, is to ensure that there's competition amongst insurers, and that may mean that we enforce antitrust laws for insurance companies at the federal level, and look for policies and promoting policies that ensure competition in that space. And lastly, I think the other strategy to keep in mind is to also look for opportunities to also promote competition among providers and among physicians, and to do so by looking at policies that might incentivize consolidation rather than integration, and also look at barriers that are impacting the ability of physicians to impact in different modes of practice. So the choice is to practice independent or in a small practice because you want to do it, because it's the right care to provide, rather than because you're being forced because of economic forces. In terms of barriers to that, I think one of the major barriers is to ensure that there isn't a pendulum swing the other way around in response to the growing concern regarding consolidation. I think there was an article in the LA Times this week, and there's been several studies that have come out in the last few years that express some concern regarding provider consolidation. A potential barrier, though, to really resolve affordability is if the response is so drastic in response that you further weaken providers and weaken physicians relative to insurance companies and strengthen insurance companies. And we've seen some of those efforts in the legislature. There was a bill, for instance, that sought to prevent providers from being able to negotiate for the provider network. And in those instances, if you do that, what we saw in the proposed mergers and the court's reasoning that denied the Anthem merger is that history has proven that strengthening the insurance industry without looking at the balance of providers has never resulted in lower premiums. So just because the market power is stronger, it doesn't mean that the actual premiums are going to go down. So we need to look at that. And the other piece is that when we look at the impact on physicians, the question is not only have they consolidated so much that they have too much market power, is how do we ensure that there's a healthy competitive environment? Perhaps for independent practices, are the burdens too high? Are we not supporting them enough? And we are working on a few initiatives where the effort is to do that, to ensure they have the capacity to compete, so we have a healthy environment in the provider marketplace.
Okay. Having been in solo practice and in group practice, I sort of hate to be isolated by myself these days. Medicine's sort of a team game, so it's a tough one. The world has changed a lot. Don, looking at the opportunities and the barriers from your point of view, and you've been a champion for value-based care and for appropriate integration, but with physicians having a leadership role nonetheless in the system on behalf of their patients. So how do you see it?
So first, I think, of course, we're asking the right question when we talk about affordability, because this 18% of GDP can't go on forever. And what happens when we hit whatever kind of wall, looking at sequesters, looking at other kind of draconian backlashes, none of that looks good. So the crowd out that's going on and the erosion of other programs. So we're on the right subject when we talk about affordability. One answer I would not posit is that we do as the U.S. Congress had nearly did in terms of repeal and replace, in terms of eliminating behavioral and maternity and moving away from community rating, all to drive a lower premium. That doesn't get to affordability, it just shifts costs. So that's what I wouldn't do. What I think I would do is accelerate this movement to value. Okay, so as we all in this room know, this is pretty much the movement away from fee-for-service and into things that are budget-based, population-based, prospective payment. That I think needs to be accelerated with the addition of new carrots and sticks. So I think it was just a week or two, the OIG came out with a report on the performance of the MSSP ACOs, and we see this sort of modest improvement. And I know that, and we know that so many of them are upside only risk, right? So moving from sort of generally saying that we should, stay the path and accelerate the value movement, I will tell you that more specifically, I think we need to create carrots and sticks that cause providers in California and around the country to move into downside risk, where the incentives are even stronger to get at the prize, which is the elimination of the 30% waste that John Rother alluded to. So you think about any CEO operating any business, manufacturing widgets or whatever good and service, if he or she walks into the office and knows that there's 30% waste in his or her factory, he or she's going to go through the roof. I mean, you're going to go right to that as a way to be more competitive and drive a lower cost price, et cetera, et cetera. So I think we have to do the same thing here. That stands as a huge opportunity for us, that elimination, quote unquote, of waste. It'll drive costs down, it'll improve quality. So you get to that with stronger incentives, downside risk, imbues that accountability. It creates a really strong incentive to eliminate that kind of waste. And so I think that would be my sort of leading suggestion in terms of a strategy.
And the challenge there, is in many ways, is to make sure that the incentive on the upside is real and that it's been determined fairly, so that in fact there really is an incentive that's retained. I know that in Massachusetts, with the alternative care model that they had in their HMO case, they had some really big incentives the first year, and everybody did save money. All the physician practices saved money. They all got a big bonus. And so they've improved the care for diabetes and coronary disease and so forth. After that year, they decided to ratchet down for the next year and say, next year the incentive was, you've already earned this place, you have to start over again. Now you can't improve diabetes and coronary artery disease care every year to a new extent. So rather than sustaining the benefit and trying to maintain it, they made the mistake of deciding to start over again and say build on top of this care improvement and achieve a new one. That wasn't going to work. So how do we get there?
So very, very good question. So this goes to the issue of how much water you can wring out of a stone, which is a problem with shared saving programs where the target or benchmark is established on historical spend, which you can reduce for a year, 2, 3, but then what? And that's what I think you're alluding to, which is and this is a barrier, and this is where we need some innovation, but where I think California, frankly, has a lot of the answer. And we need better models is the question. So, one of the problems we have is in most ACO programs, certainly the Medicare one, but commercial ones we see around the country where they're upside only, they are based on historical spend and have other flaws. So you take the Medicare program, fee-for-service platform, open network, go anywhere you want, very little patient engagement. It has all of the ingredients to prove a disaster, right? It's lucky that we're having as much success as we are, frankly. It isn't that much of a mystery on how to create a better model. We have that in California, where you have, closed networks. Heck, we have now narrow networks. We have global capitation where the incentives are aligned. So, one of my, I think, sort of levels of impatience is that the rest of the country doesn't do a better job moving more rapidly to emulate the model that probably works best, which is in California. So that's a big challenge.
Okay.
So.
Ken, you radically and positively transformed the VA. You kind of set the tone for how we're going to measure quality at NQF, and now you're looking at population health. I mean, what an amazing eclectic career you've had. I thought you were going to be scuba diving all the time now. But so what are you thinking about these topics in terms of the opportunities and the barriers?
Well, I'm thinking that we're a panel of blind folks up here feeling an elephant, and we're kind of describing what we see from the part that we're feeling, the elephant being affordability. And most of the comments so far today and on this panel really have dealt with payment issues of various types. And so I'd like to maybe go upstream a little bit and focus on 3 strategies that, while they clearly involve payment, they're not necessarily focused on payment per se. So the first thing that I think I would do to improve affordability is to better use and leverage technology. There's an incredible amount of activity going on out there in technology and the use of advanced information and communication technologies, telehealth, mHealth, go down the alphabet soup there. But it's all chaotic, and there's no concerted overall strategy for how do we use those technology to increase access. Indeed, it wasn't that long ago when access clearly had to be defined by face-to-face visits. But that view of access is an anachronism now. We have lots of other ways of accessing folks and touching them, exchanging the information, providing direction, all the things that we do as clinicians. We can use technology to better coordinate and customize care to individuals. We can use technology to help providers function at the top of their skills. The pilots that are going on here in California on community paramedicine are perhaps a good example of how technology will be able to be leveraged to deal with providing more community-based care. We can use technology to target the persons who are most in need of care and at a point in time when their care can be more optimal than when they show up on death's doorstep in the emergency department. So there's a lot of things we could be doing with technology that are being done kind of episodically or haphazardly. But if we had a more coherent and concerted strategy, I think there's a lot that we could do to improve the affordability of care. The second strategy that I would put on my list is to pay much more attention to the social determinants of health. Many of our most expensive patients, the ones that drive up costs for everybody, are that expensive because of social factors, whether it's housing or lack of transportation or food insecurity or all the other things that fall into that bucket of social determinants of health. And we tend to lose sight often in healthcare that actually the single most important thing we could do to improve health here in California, here in America, would be to increase the number of college graduates or persons with other secondary education. It has nothing to do with healthcare per se, but because there are so many other things that stem from having education that ultimately improve health. So if we really want to increase or improve affordability, we need to focus on creating a culture of health and all the things that go with that as far as addressing the social factors that affect health. The third strategy that I would put on my list is really focusing on safety and patient safety. That may seem like a bit of an outlier, but I'm always reminded when Paul O'Neill took the helm at Alcoa and focused on safety as his #1 priority, economic performance, every other area of the organization dramatically improved. And in part, we need to focus on safety because there are still far too many people being hurt by the processes of healthcare. But perhaps more importantly, it provides a lens for looking at a lot of other things. And that lens really shows many other opportunities for improvement. So I think that if we really were to focus again in while a lot has, and I should acknowledge that a lot has happened in patient safety in the last decade, there's still an awful lot that needs to be done. And you may be able to argue about the statistics, but when medical errors are the third leading cause of death in the United States, it suggests that we have a ways to go there. So as far as barriers, again, I would perhaps focus on 3. One is payment, and again, there are lots of perverse things in how we pay for services that drive costs up. There's insufficient transparency of where the costs are coming from and what we're actually paying for. And then the third area is that we continue to have, despite the plethora of information that exists today, we still have insufficient data on outcomes, what drives outcomes, what parts of the care processes really contribute to that, and where the real value is in the care process. So that would be my short list.
Wow.
Not that I disagree with what others have said, but taking perhaps a little different slant at it.
Good. Well, we can get into that in a discussion later. Janet, you're not on a hot seat. You're on a place of opportunity with the Kaiser Health Plan in Northern California. It's a tremendous opportunity. We actually crossed paths. I was leaving as director of health in Hawaii, coming back to San Francisco. You were heading to Hawaii to direct the Kaiser plan there. But from your vantage point, with the biggest plan in the state and one that has been a pioneer in so many ways, what do you think is the opportunities and the barriers?
Well, first I want to thank you for inviting me to the panel. And for those of you who don't know Kaiser, Permanente, we provide care and coverage for over 11.5 million members across the 8 states and Washington, D.C. And here in California, we cover 8.5 million members. And our mission, we were founded on a mission, and I was really struck by what Suzanne said around having a dream, if organizations were founded around a dream, and we certainly were. We were founded on a mission to provide high-quality, affordable health care to improve the health of individuals and the communities that we serve. And within delivering that mission, we have a couple of really fundamental beliefs. One is that truly the pursuit of life, liberty, and happiness cannot be achieved without total health. And that's for families, for individuals, for our communities. And secondly, every individual deserves the opportunity to have good beginnings and dignified endings. So when I've been listening today to the talk, and I'm really glad I'm on the provider panel and not on the health plan panel, because it's really tough to be on the strictly on the payer side. Most of what we hear really amounts to cost shifting. How much are you going to make the patient, your employee share the cost? It's around moving design elements around on networks or benefits. It's about how much subsidies can you get from the government or regulation. And in payment reform, while necessary, it's really only a fraction of the formula to really address affordability in healthcare in our country. Because the other component really is around the delivery of care and care transformation, which is what Ken was talking about. And without that, without a way to incent the care delivery system to really transform and really to do the right things on behalf of members and our economics, the payment reforms might only moderate inflation on a year-to-year basis, but long-term, it will not prevent sort of the crushing impact on families and individuals of escalating premium costs for healthcare. And I want to give you a couple of examples, so I'm going to try to speed talk it because we've been talking conceptually about what does that really mean. So I want to give you a couple of examples of what we're doing at Kaiser Permanente. And these are things that there are no CTP codes. There is no way to get reimbursed by fee-for-service mechanisms to do these kinds of things. So you'll be the judge to say, shouldn't everyone be doing this? So a very simple example is using our technology. We put electronic medical records everywhere, so we're completely connected. But we're going beyond just having coordination, but using the power of predictive analytics. So if you're in a hospital today, right, you're in a hospital today, and you guys, if you think about this, if you watch all the television shows and soap operas, you'll see that event happens where bells go off and everyone goes rushing to your side to suddenly save you because you had a crash, right? Well, I'm here to tell you that crash probably started happening about 48 hours to 12 hours before anybody really noticed it was happening, right? Because there's too many factors going on in a hospital to be able to monitor the deterioration of a patient. So what we are doing today is we have an algorithm that extracts 72 variables in your record and your diagnostics while you're in the hospital on an hourly basis. No human being can do that. On an hourly basis, and that algorithm produces a risk score which will alert the team that you are somebody who is approaching deterioration and needs to be seen by a rapid team. We did a pilot of this in 6 facilities, and in 6 months, we calculated 1 day length of stay reduced in the ICU, half a day in our med-surg, and 60 lives saved. Now, when we spread this across our 38 hospitals in our footprint, we are talking about 900 lives saved, 14,000 days avoided every year across our footprint. Everyone should be doing something like this, right? Because you can see how high quality care right? High quality care leads to affordability in healthcare, right? A second thing I want to talk about is technology as a force for equality and equity in our country. And so what we're doing is telehealth, teleneurologists. Whoever knew there would be that kind of subspecialty. But in the corners of our hospitals and our regions where it's rural healthcare and you don't have access to a neurologist, right, the interventional neurologist, you might show up in the ED stroke, right? If you have a stroke, you show up in an ED, and we all know that time is of an essence. The longer your brain is without oxygen or limited oxygen, the more damage you're going to have. So we set standards and we say we'd like to get everybody in within 40 minutes, door to needle for treatment to remove a block, right? To get oxygen back to your brain. Well, we now have through telemedicine, neurologists who are at home working as a group where we actually connect them in the CT suite, and they can look at the scan and go ahead and order the appropriate treatment. Across the country, there's only 17% of hospitals that can do that within 30 minutes. And at Kaiser Permanente, we can do it 70% of the time within 30 minutes.
That's pretty cool stuff.
Right? So those
Yeah.
are the example. And so
Yeah.
what I want to tell you that it's very difficult, and I share these stories only as a concrete example of the kinds of things that healthcare systems want to do. It's not that Kaiser's the only one who wants to. Hospitals, doctors, they want to do it, but the fee-for-service system, it doesn't incent them to do these
And Ken
things.
brought some of these kind of, the ideas up about looking at, at new innovations and apply them. I mean, we're still talking about the fact that it's 5% of our patients spend 50% of the total healthcare dollar. There's where a lot of the money should be somehow focused. But we're also looking at that population we alluded to here, at least in the last two comments, about people who are going to be in that 5%. They're not there yet. They're a couple steps away, but we could predict that they're going to be there, and we try to move in. We won't live forever, but we can do some things there. So, I mean, in terms of the innovation, some of these models, we have that on one side. We have, the fact that we don't pay for all these innovations at this point. How do you think, what do you think we should be doing here in terms of what should we take home for what we should do as next steps as a society to try to get at the rising costs, the unaffordability in this age where other sectors are doing some amazing things with new technology, new thinking, and so forth? Don and Francisco, you want to take a shot?
Go ahead.
What can doctors do?
So is this the game changer question, right?
And this is doctors and nurses, and it's the team, it's the caregivers.
Well, I think that the game changer is it starts how we start the conversation. And challenging the key assumptions that we make when we address these issues. There's two, I think, that are highlighted in our conversation today. One of them is that one of the key assumptions is that the only way to create affordability is by further squeezing. So you squeeze down because you can. So that will give you lower costs and higher affordability. But in fact, I think maybe the question should be, how do you use the resources that you have to create efficiencies? And there are some examples on things that we're working on where you actually provide more resources to get higher quality and lower costs. We're working on a project with PBGH and Blue Shield in our foundation where we're focusing on practices that are not doing a good job with their diabetes patients. So what do? You invest resources to teach them how to do a better job there. And the end goal would be higher quality, lower costs, instead of just squeezing them or pushing them out of the network. It's a different solution. The other example of that would be the Inland Empire Health Plan, who is viewed in the physician community and I think in the healthcare community as a high-performing plan that's providing Medi-Cal services. It's still low payment, but the burdens to provide care, they do a good job of lowering those. So it creates quality and high efficiencies. And then I know we're short on time, but one other key assumption.
Give everybody a chance to comment.
I think the other key assumption that needs to be challenge is that instead of asking about healthcare coverage, I think the right question is healthcare access. How are we going to provide that? So maybe it's through insurance coverage, or maybe it's through some other means, but really the end goal is providing health care.
And there's the access to a what, and defining what that what is also part of it. A changing sort of access with telehealth and with new biosensing, which in the cardiology space is really, really exciting. People with heart failure could live a lot longer if they're connected, their devices are actually connected to the Internet of Things. A little worrisome to me, though, because we could hack into that Internet of Things and do a lot of damage to a lot of people. And so FDA needs to deal with that. But what do you think, Don?
So the question is what kind of innovations we should be pursuing. So one technological, there are many to talk about, and then one programmatic. On the technological side, just picking up with what's been said about data mining. So the whole predictive modeling, you see so much innovation where you see so much good success and innovation now, it has to do with really better use of data. You know, storing the data, reading the data, predicting the data, knowing who that 5% is going to be, you know, next year, the following year. So I would just say in terms of technical or technological innovations, improvements in that area should be sought and they should be incentivized. Programmatically,
a long-standing quest toward interoperability that we
well,
never seem to get to.
interoperability, the sharing of the data, you know, the harmonization of different data sets, et cetera, all of that needs to be done so that we know the acuity of our population better. You need to know that for financial reasons, but you need to know it for quality reasons. I mean, if you know those 55-year-olds that are going to have a heart attack in about 3 years, you can intervene early and you can do outreach and you can prevent a lot of things. So the prevention and early intervention has a lot to do with the management of data. Programmatically, I could talk about 19 different things, but one that stands out to me is original Medicare. So 2/3 of the seniors are in this.
Get ready out there, by the way, if you have a question, get ready and get your hand up, because we only have about 3 or 4 minutes left. So if you have a question, get your hand up and we'll get a mic to you.
A dysfunctional program, utterly Wild West, no management, et cetera, converting that into at least providing options within original Medicare where you can have a direct contract between CMS and sophisticated groups, point of service like benefit design, sort of ACOs done right. If we could really design the right ACO with all of the right ingredients, that would be a wonderful thing to achieve. I call it an innovation, maybe it's more advocacy, but nonetheless, there's a big gaping hole in the American landscape of dysfunction that could be fixed there, and I would work on that.
Okay. Comments?
So I'm mindful of the clock. So if I were to do one thing that might be a game changer, is simply to change the payment system. And I certainly want to applaud all the work that's been going on, Suzanne and others, on value-based care, but the payment system's too complicated, certainly from the clinician's perspective. We need to move to a capitation-based global payment system that allows both upside and downside risk, and that's simple and easy to understand.
And if total capitation seems hard to do, you could start with risk adjustment that was focused on health outcomes versus just age and utilization. I think that utilization is a byproduct of fee-for-service, and the more you do, the more you make. And so by asking providers to really deliver health outcomes, it would be a nice step towards the kind of future that we just talked about. And I will say that when offered, just a nice anecdote for you, when we offer patients the option of coming in for an appointment or doing like FaceTime, face-to-face video, or phone, 50% of people choose to do it by phone or video because it saves money, especially with all these high deductible plans. Right.
And get ready for the millennials. That's exactly what they want.
Yeah, that's what they want.
That's
That's
exactly
access.
what they're
That's a
going to want.
form
No
of
questions
access.
out there yet? Looking around, okay. All right, so I guess my thoughts would be in the provider world, one of the questions I have, is everybody going to be working for some big, under some umbrella at some point, the direction we're going right now? And there'll maybe be 6 or 8 of those umbrellas within a geography. Or do we have independence? I mean, one of the most unknown factors about Kaiser Permanente is that Permanente is an independent medical group. They aren't part of Kaiser. They just contract with each other. So, I mean, physicians, we talked about a lot of different models for doctors. And for hospitals, we didn't mention so much, but it's the same kind of model. Is there a benefit from having an independent provider, physician and other provider community, and independent hospital community and independent payer community that interact with each other with maybe government as an overseer, or should we just integrate all the way? What's your thought?
So I think that our experience is that physicians, well, a whole lot of physicians want to be independent. I mean, across the country, the great majority of physicians are quite independent and in small practice, and I think they want to be that way. And so the answer there may be something in the nature of independent practice associations, a perfectly awful name with the acronym of IPA, but nonetheless, some level of organization so there's centralized supports where you have the data and the IT, but supporting the independence which they want. And our geography almost requires. I mean, a whole lot of the United States is rural. It isn't all just downtown San Francisco. So I think there's going to be this interesting kind of blend of independent and then organizational. It remains to be seen. We'd have to talk to Jamie Robinson about the economics of hiring physicians into high costs structure hospital systems and whether that's sustainable. But enough of my editorializing.
Yep.
So integration is one of those terms that has multiple different meanings and is thrown around as if it meant one thing, and it doesn't. And when we talk about integration, there's financial integration, administrative integration, clinical integration. The evidence is very clear that you don't have to be financially and not necessarily administratively integrated to be clinically integrated. And what we're really talking about, and to achieve the outcomes that we'd like, we need clinical integration. And that can be achieved with a multiplicity of administrative and financial structures.
So we're not heading for the National Health Service yet, huh? Okay. Well, you know, I think this has been a really interesting discussion. There's one question back there. We're going to let that one question come through. This is it, though. We're one question, and my instructions are we're done. All right. Yes?
Okay. So a lot of the conversation is around data being in the solution, big data, being able to drill in, find the risks that exist. All the efforts around creating some sort of health information exchange or some sort of standard like the banking system has that enables ATMs around the world have not happened. How do we as an industry make that happen and engage all the parties into agreeing to common standards to find that data to deliver better outcome?
Panel? Ken, you want to take it?
Well, one way would be to view HIE or HIT in the broad sense really as a commodity, and health systems in the future aren't going to be able to operate without electronic health records and health information exchange and other tools. And as long as it's a for-profit proprietary business, we're going to have these problems with interoperability and systems that don't talk with each other and can't coordinate. And if we would move our thinking that as more a commodity, and that the government has a role to play in setting the standards and driving the interoperability in a stronger way than it has in the past, I think many of these issues would go away.
I was going to say, in addition, purchasers have a big role and can influence standardization. Groups like the Pacific Business Health Group here in California and many other communities, you can influence by the goals that you set, the expectations, requirements, reporting. And so we've seen some standardization in California from our regulators. So it's a combination.
They should demand it. They should be demanding it. They should demand it. Go ahead. One final comment, and we're going to wrap up.
And can you hear me now?
Yeah.
I would say that EHR and the implementation of EHR has probably been one of the biggest administrative burdens for physicians. And the irony of it is the goal was to promote integration, but without interoperability, it's actually promoted consolidation without the upsides of integration. So I think that's one of the key components that we need to ensure that there's integration among practices. And to give patients the mobility that they need.
Yeah, I want to thank Janet, Ken, Don, Francisco. You guys did a great job. I'll just take the moderator's prerogative to say one more thing about that interoperability, which is I think we're going to have the EHR of today is going to be garbage in the future. The EHR that causes physicians and other practitioners to spend hours more each day doing the work and hours away from looking and talking to their patient will be replaced by something much, much better. But we need it. We need it now. It's just not where it needs to be. Thank the panel very much.
Thank you. Thank you, everyone. Thank you, Dr. Lewin, Francisco, Don, Ken, and Janet. Thank you very much.